All right, well, it is 8:01. We'll go ahead and get started. Good evening, and thank you for those who are dialing in both live here with us tonight, as well as who are dialing in asynchronously through our YouTube channel. This is a lecture on menstrual disorders in athletes, which will be presented by Dr. Suzanne Hecht of the University of Minnesota. We're very pleased and fortunate to have her speaking to us tonight. I am Dr. Nathaniel Nye. I am the Assistant Program Director at the National Capital Consortium Sports Medicine Fellowship. I am an Assistant Professor of Family Medicine, and I am a member of AMSSM's Online Education, Fellows Online Education Committee, and of which which presents this lecture series for the AMSSM. Along with in collaboration with the fellowship committee. So before we dive in too much into tonight's topic, I just want to mention a couple of things. This is our last lecture for the academic year 2020 to 2021, which is awesome and it's exciting. It's been a great year. It's been certainly a amazing thing to see this lecture series come together, and I think it's been well received and been a great resource for fellows, hopefully. We will be kicking off another round of lectures throughout the 2021 and 2022 academic year. And as we are in the midst of planning for that lecture series, there will be some changes. And so look for those details to be forthcoming, but a couple of just little, key points is that one, we are going to be delivering these lectures at a set date and time every week. We haven't decided specifically on what time and day that will be, but it will probably be on a Tuesday, Wednesday, or Thursday evening. And then some of them will be live and some will be asynchronously presented as a recording. The other piece for you to be aware of is that if not all, very close to all of the lectures will be accompanied by a 15 to 20 minute podcast, audio only version, which will be more mobile friendly and user friendly to fellows. So those are two key changes that we intend to implement this coming year. Okay. So just a little bit of housekeeping tonight with this lecture. This lecture is intended to serve as an adjunct to your individual program's educational programming, not to replace it. Our goal as the AMSSM Fellows Online Education Committee is to provide you, the fellow, with direct access to educational experiences with some of our top national experts and invited guests, both AMSSM members and other outside experts. And this is to primarily to assist you in your preparation for the CAQ exam. Please keep your device on mute, and you can keep your video off. This will be recorded and will be available through AMSSM's YouTube channel after the presentation. Please do submit any questions you may have for Dr. Hecht through the chat function, and include your name and program if you wish. I will be going through those questions and we'll ask those as we reach the Q&A portion at the end. We would greatly appreciate if you would fill in the evaluation, which will be available in the chat feature. There will be a link to complete that. Okay, without further ado, I would like to introduce Dr. Hecht, our speaker for tonight. She will be, again, speaking on menstrual disorders in the athlete, which I think could be rephrased as the effects of exercise on the female reproductive system, and even could be expanded out to its effects on the body. Dr. Hecht is an associate professor in the Department of Family Medicine and Community Health at the University of Minnesota. She is the program director, teaches fellows at the University of Minnesota Sports Medicine Fellowship. And she's also a team physician for Gopher Athletics. Go Big Ten. I'm a Buckeye. And she is a bone health consultant for the UM Department of Orthopedics. She is well known for her role as a team physician for the U.S. figure skating national team. And to boot, she's been very active academically. She has been a board of directors with the AMSSM and been a chair of the research committee. She is a fellow of the AMSSM, and she's also a fellow of the ACSM. So she is well prepared and is highly regarded as an expert nationally in this topic. Will have a lot to say, and I'm sure it'll be a challenge to cram all of it into one lecture. So with that, Suzanne, thank you again for joining us, and it's all you. I will take it off screen share.
Great, thanks so much. Let me see if I can get to my slides now. Oops, I already messed up, see? There. All right, here we go. That's looking more promising. Oops, I'm patient. All right, well, thanks, Dr. Nye, and thank you all. I'm going to put you guys over here on my screen. Thank you all for joining this evening. I know it's getting to be a nice time of the year, although in Minnesota, you guys will never believe this. It's like ridiculously hot, like upper 90s and major humidity. And I was in North Carolina this weekend with my daughter for a soccer tournament, and it was actually nicer there than here. So I'm not exactly sure what's going on, but hopefully you can stay inside where you are and not be too hot. So I don't have any disclosures, and I would like to thank the AMSSM, Dr. Nye, and the committee for inviting me to give this talk. I think the National Fellows Lecture, let me say it correctly, is such a great asset and such a wonderful thing that came out of some of the darkness of COVID. So I really appreciate all the work that people have done to put this together and offers great experts and these different topics. It's amazing because certainly as a fellowship director, there's some areas that I love, you know, having John Dresner talk, someone else. So I think it's wonderful. All right. So for those of you who know me, you might actually know that I am more of a bone health sort of person. Love the bone, love the skeleton, like, you know, like get excited about fractures and breast fractures and things like that. If you're that type of person, you're interested in those topics, you're going to definitely come across menstrual dysfunction. And if you're not, and you're taking care of those athletes, you should be addressing it. So I hope to give you sort of some better ideas on how to approach it and maybe make it a little bit more manageable. So today, an overview would be that I'll just start with a case just to kind of get us, you know, on the same page. Review the terminology, which in the gynecology world is sometimes confusing, and people are like, oh yeah, I kind of forgot about that. Talk a little bit about the epidemiology of some of these problems. We'll review the Triad and the RES in case you're not super familiar with those, because it all ties in together. Then we'll go on to the menstrual disorders. I'll spend most of the time, because this is most likely what you'll see at the end of the day when you done evaluating everything, is Amenorrhea, Menorrhea. We'll talk a little bit about polycystic ovarian syndrome, luteal phase deficiency, which is not luteal phase defect anymore. So that was good learning for me too, when I'm preparing for this. And then dysmenorrhea, and then we'll circle back, which is the new phrase of the virtual world, circle back to the case. All right, so here's some terminology for you guys. So Menorrhea is sort of the happy state of affairs. You're getting your period every month. It's about 28 days. It can be plus or minus 3 days, and that's the most typical pattern. About 2/3 of women will have that. The normal range can be kind of long, though. It can be 18 to 40 days. So it can sort of span even the times of some of the diagnoses that are concerning. So that makes it a little hard to sort out sometimes, but I was just trying to remember the sort of 28 plus or minus 3 days is a good number. Primary menorrhea is basically no onset of menarche by age 15. So no menstrual period. If you're 15 years old and you haven't had your first menstrual period, it's time to start, you know, getting a little more concerned about that, getting someone evaluated. So that's definitely a little bit there. some clinicians are recommending, especially in the United States, as the age of menarche tends to be decreasing, that if you are 14-year-old and you haven't had your first menstrual period and you've already had breast development and it's been longer than 3 years, then you might want to start on the road to working this up a little bit. Secondary menorrhea is a more common thing, and that's no menses for 3 consecutive months in a female who was previously menstruating. And I do want to remind everybody that your first year after menarche is, I kind of call it like a free pass. And so you always get that free pass first year as the whole system is sort of getting geared up and settled in and starting to work more appropriately. In some cases, it can be up to years, but I think 1 year is a typical American thing to remember. So free pass for first year. Oligomenorrhea is basically menstrual periods that are greater than 35 days apart. So they're kind of spread out a little bit. And so when you ask athletes about this, when you ask athletes about this, and they're like, yeah, I get my period, it's regular and everything. And if you sometimes ask them more details, sometimes you'll find out. And they'll be like, oh, it's like 36 to 38 days apart. And they think that's just kind of like normal for them. So they think that's all right. And it seems to come. And so they're like, oh, it's a little longer than my friends, but they don't always realize that that's a problem. So we started addressing it. Delayed menarche, I think this one's important as well. We touched on it a little bit. So 15 years or older is considered delayed menarche, and that's a risk factor for some triad-related phenomena, and also deserve bigger workups. So let's talk about this case. This is about a real patient. This is a real patient of mine, actually. So this is an 18-year-old freshman female distance runner, and she's here for her PPE. She reported that she's had 1.5 years of Menorrhea. And you ask her a little bit more about that. She had her first menstrual period at 16.5, but then really hasn't had any periods after that. So basically, she's had one menstrual period. So already you're like, that's not quite right. So her vital signs, she's 5'6", she weighs 110 pounds, her BMI is 17.6. She reports no history of fractures or bone stress injuries. And then she tells you, emphatically when you ask her about like her nutrition, that she's a good and healthy eater. She's, all the right things, and she's super confident of that. So what I'd like you to do is sort of think about this as we go through, and then we'll talk about her more at the end. So think about what would you do next. So let's just talk a little bit about the epidemiology of amenorrhea. It's actually in the United States, and most women who aren't athletes, it's actually not super common, 3 to 4%. You'll run into it. Obviously, that's taking out pregnancy, lactation, and menopause. So don't ever forget to think about, could this athlete be pregnant? That's an important question. And in athletes, some of the more recent literature has found that 52% of exercising women experience subtle menstrual disturbances, such as luteal phase, should be deficiency, not defects in anovulation. And there's a huge range of amenorrhea within different sports and athletics, somewhere between 3 and 69%. So it can be in any sport. Seems that some of the more appearance-driven sports, or sports that are a lean build and a smallness to you are advantageous, seem to be more susceptible. I like this study. It's a newer one. Let me see, I forget the year. Yeah, 2020, so it's really pretty new. Glad this person was publishing during the pandemic. That's impressive. So this is a young athletes, which is a little more of a challenging area, and it was a Finnish study, and they looked at 283 athletes, and they looked at them at age 14 to 16, and then they took that same cohort and followed them up again at age 18 to 20. So they started out with more in the beginning, and they lost some to follow up, and they ended up with like 228. And so this was interesting because they basically found no difference in 14 to 16-year-old prevalence of menstrual dysfunction in athletes compared to non-athletes athletic controls. So that was good. although almost 5% of those athletes with primary amenorrhea compared to none in the controls. So right there, that's a stark difference. And then once they were 18 to 20 years old, almost 40% of them had menstrual dysfunction compared to non-athletes, where it was only about 6%. And so that included amenorrhea, oligomenorrhea, metrics that they were asked about. And then they asked them more about body dissatisfaction, which is kind of makes this study like a little more unique than some of the other ones. And they found that both groups had body weight dissatisfaction, but athletes are actually doing better in this category. So only 20%, which is still pretty high, versus 40% in the non-athletes. So the athletes are feeling better about their body, but still not super happy overall. And they're having more menstrual dysfunction. This study had to put this one because it's one of my former fellows, Karen Van Bach, who's at the University of Colorado. And this is an interesting spin on some of these studies. So they looked at 90 athletes between 13 and 18 years old at PPEs for high school sports. And they found that 28% had menstrual dysfunction, which is defined as oligo or amenorrhea or delayed menarche. This is very disturbing. 44% of those athletes believe that it was, of all the athletes, 44% believed it was normal to lose your period if you were training hard for your sport. So clearly there's sort of a media and a cultural, maybe coaching, education to be done in this arena, because we want athletes to understand, and their parents and their doctors and their coaches, that that's not normal, that you can train hard for your sport and still have regular menstrual cycles. And then they also did a comparison looking at some mood states. It's called the PAMS, and they found that the athletes with menstrual dysfunction compared to those without had more fatigue, pain, and anxiety. So that was kind of an interesting finding too, and may relate back to sort of, nutritional deficiencies. So I have to talk about this topic without going over the Triad and the Red S a little bit. So just to take you guys back a long ways, back to when I was a first-year fellow in 1997. It was so long ago, I can't even believe it. And this is the model that we were using back then. It was the first position stand from the AMSSM on the Triad. And this was the model we were using for the Triad. So sort of this triangle shape. It had disordered eating up top, osteoporosis this corner, and amenorrhea down in this other corner. So this is kind of what we were working off through like most of my fellowship. And then I trained at UCLA and was fortunate enough to be on the faculty and work with Aurelia Nativ, who was the lead author on the 2007 revision of the AMSSM Triad position stand. And that was a major labor of love. If you ever talked to any of the folks on the writing committee, it took a long time and a lot of work. And they came up with a new conceptual model at that time. And some of that is because, we were seeing athletes for sure that really had unintentional underfueling, and they didn't really have disordered eating. They just didn't understand that they weren't eating enough. And so that's one of the things that helped set this genesis. And so they came up with this spectrum. And so on this end, the green side is all the good things. So optimal energy availability, Menorrhea, so regular menstrual periods, and optimal bone health, which makes me so happy. Down here on the red end is all of the things that are sort of more concerning and more worrisome. So this can be low energy availability that's pretty severe with or without an eating disorder. And typically there's an eating disorder going on once you get to this point. Not always, but typically. And then they define something called functional hypothalamic amenorrhea, which is loss of menstrual periods. We'll talk about that more. And over here on this side is osteoporosis. And then the thing I really love about this is it's a little more dynamic, and basically this sort of blue middle section, which means you're not really at the greatest, but you're not at the worst either. So you're somewhere in between in these zones. It could potentially be, on a green on one side, a blue on another one, and a red on the other one. So that makes it more dynamic and more flexible. So for the sort of energy availability, be reduced energy availability, not as bad, with or without disordered eating. So that kind of encapsulates that athlete with inadvertent underfueling is what we call it. these subclinical menstrual disorders, where things like luteal phase deficiency fits in, and they may not have osteoporosis, but maybe they have low bone mineral density for their chronologic age. So trying to capture this group too, that, you know, it's better to capture them earlier than when they get all the way over to the red. So this is just another way of sort of representing the spectrum, and you can just sort of see these ranges here. We're going to spend the vast majority of our time talking about sort of this green area. I just wanted to have you take a look at that so you knew what we were doing in a different format to look at it. This is one of the most important works that sort of tied the female athlete triad all together. And so I want to make you aware of it. It was done by Dr. Cobb, and there were 91 competitive distance runners. They were young women. And they found in this study that disordered eating was strongly related to menstrual irregularity. They found that menstrual irregularity was associated with low bone mineral density, and the disordered eating was associated with low bone mineral density, even in the absence of menstrual irregularity. So that was suggesting that the missing calories can have a direct effect on the bone. So back in 2002, there was an organization, at the time it was formed, it was called the Female Athlete Triad Coalition. It's been renamed to include males, and we'll talk a little bit about the guys. We don't want to leave them out of this discussion, even though they don't have menstrual periods. So we're not suggesting you get some, because I don't think you would like that. So this is a nonprofit organization. It represented key medical and athletic groups and concerned individuals. So it was a really diverse type of group. I was the AMSSM representative for a number of years on this group, and so I got more involved with it. It tries to promote optimal health and well-being for female athletes, active girls and women. And here's the website if you want to take a look at it. You can join as a member, and for fellows, it's like super cheap. I think it's like $25 a year. If you're a program director, will sign off, or if you're a resident or you know residents who are interested in this, it's same deal. I think any student basically is how they look at it. So think about that as a kind of a good option for learning more about these problems. So I showed you the 2007 position stand. In 2014, this group, the Female Athlete Triad Coalition, met, and they came up with a paper trying to expand on some of the areas that they weren't able to complete in the 2007 position stand due to like space constraints and decision by committee and some different things like that. And this one tried to address more of the treatment and how to risk stratify people and try to talk about return to play. So more geared for the clinicians, which was great because the 2007 position stand left a lot of unanswered questions. So this is good reading. I think as fellows, that'd be what I would consider to be like seminal articles that you should read. And I don't know if I haven't looked at that top 100 list in a long time, so that we have for AMSSM, but hopefully that's on there. If not, I'll recommend that we go up to 101. And then the IOC sort of had a different charge, and in 2014, Dr. Mountjoy, who's on the IOC Medical Commission, she's a team physician, primary care sports medicine in Canada. They came up with something called RED-S, which I'm hopeful that most of you have heard of. Stands for Relative Energy Deficiency in Sport. And I think there's some really good things about this. I like that thinking about the role of relative energy deficiency, not only being a problem for women, but also for men, because why would it be so gender selective? I never understood. So this sort of takes that and, takes it a step away from just the female athlete triad. And so this is a nice thing. They tried to include some other areas that possibly energy deficiency can have effects on that aren't included in their, the triad model. So you guys can take a look at both of those. I think it's good to know both of them. They had a sort of a different mission because they had to take this model and have it be very consumable and make it, usable for physicians and educators and coaches and athletes around the world. So that's a lot different than sort of potentially the US through the American College of Sports Medicine, or say in Canada. And then in 2018, they had an update on that, so that you might want to take a look at those articles as well. I think they're important in this literature. So let's get into it. So amenorrhea. So typically one way to think about amenorrhea, it's kind of mind-boggling if you just put up like an entire list of all the things that can cause amenorrhea. No one can remember that. So I try to think of it in these three big categories: anatomic, ovarian failure, and then chronic ovulation. And basically, for most athletes, you're probably going to be down in this category, the third one, chronic anovulation. These things happen, but they're much, much rarer. So here's a differential diagnosis of anatomic causing amenorrhea. So you can see those. So, a more classic one is you have an abnormally shaped uterus, and you can't, the blood from your menses can't actually get out because of the shape of your uterus. And so that's probably one of the more, not that it's common by any means, but one of the top causes of primary menorrhea. That's anatomic. Pregnancy, of course, obviously, that's a good one. So that's easy to rule in and rule out, hopefully. Ovarian failure, it's actually a really big differential. And if you really start getting into it, it's like a million endocrinopathies, and it make your head spin. You can't even really read the whole list because you'll be like, what the heck? It's too much. And that's not what the heck, it's what the heck. And so I try to break it down in these categories. So I like this classification: idiopathic, of course, meaning we don't know why you're having this, which happens. And then the primary kind, and then secondary, which is probably a little bit more common from like cancer treatments and things along those lines. Oops, I skipped one. Oh, no. All right, chronic anovulation. We're going to kind of spend most of our time in this area. There's a number of things that can cause this, and it's all along the hypothalamic pituitary ovarian axis. Typically, there's also adrenal causes. But I think these are things that you should be thinking about and looking for. Certainly, hyperprolactinemia is an important cause, and you should be on the lookout for that. Hypothyroidism, primary pituitary disease, premature ovarian failure can actually cause you not to ovulate. We don't know why is, again, the last one. And the one that, we really see the most is here, hypothalamic dysfunction. And anorexia is just one example of that. So it could be like nutritional deficiencies. So you've got this athlete in front of you, and you're going to take a history from them about their amenorrhea, and it can be a little overwhelming, just like anytime you're dealing like with a triad athlete or something. So just try to sort of focus on the main problem that brought them in, and then try to get a little tidbits of information in the other areas. Otherwise, athletes like so confused at the end. They're like, well, this is like sacral stress fracture, but mostly we talked about my eating, so I didn't really understand that. So you can keep working on it over time. It doesn't all have to be like in one appointment, and it's actually really hard to fit it all in anyways. It's a little overwhelming. So I think you want to ask them a lot more about their menstrual history. What are their menstrual periods like? And before you start to like launch into that topic, I like to say, and obviously they're coming in because they're not having their menstrual periods, or maybe you're finding them, but I like to explain to them that your menstrual function can have a big effect on your bone health. And so that's one of the reasons we like to ask you a lot of questions about it. Otherwise, I think, and sometimes I've seen this more with our male fellows, that like the male fellow's a little uncomfortable, the athlete's a little uncomfortable. I think you just like kind of practice it like that. Then the athlete's like, oh yeah. And it's the same thing when you start asking about nutritional history. So if you start launching into like, do you purge or, binge or, all these things, you take laxatives, sometimes without like a little preface of like, oh, your nutritional health is super important for your performance. So maybe you could tell me a little bit about what you eat. Do you have any eating things you don't eat? One of my favorite questions is, what do you like to eat for a snack? I always get kind of some interesting answers to that. And sometimes they're very reassuring, and other times I'm like, that's worrisome, particularly if they take a long time to sort of think about a snack that they like, that special snack. I once had an athlete tell me after about, a minute of trying to think of something, that on a really special occasion for a special snack, she would eat a half a bagel. So I was like, oh, this is a long relationship with this athlete. So anyways, you can ask them a lot of, ask them about their nutritional history. Obviously, ask them about puberty, when they got their first menstrual period. It's important to ask about bone stress injury or other fractures, particularly, fractures that seem what we would call insufficiency fractures. They're sort of out of proportion to the amount of trauma. Sometimes it's hard to make a judgment on that. But if you have a kid accumulating lots of fractures, and you have to start thinking, oh, maybe there's something going on here with their bone health. Medication history, along with past medical history. Obviously, if they were, say on lots of prednisone because they have juvenile rheumatoid arthritis and they had a hard time managing it, or other strong immunosuppressant medications, that can be important history for you as well. Family history, and I actually have a lot of athletes with eating disorders who try to assure me the reason they're having amenorrhea is because their mother had amenorrhea. And there's some relationship there, but I think a lot of times the relationship is that their mother maybe has some eating issues as well to go with it. But there's definitely some genetics, that the way people mature, and they, in certain sports, obviously gymnastics is a great example. Usually you're a better athlete in gymnastics if you're smaller and you mature later. So I think they're generally selected out. So the higher level kids generally have a later onset puberty. And then the question is, how much is the training and maybe not getting enough nutrition contributing to that? I think trying to get some information on that is important. Sexual history is obviously important. You have to worry about pregnancy is usually the main one. And I've had athletes that have assured me that they're not pregnant and they've never had intercourse, and sure they're obviously like 26 weeks pregnant, and so there's actually other things going on there that you can delve into. So the physical exam, I think you want to be looking at their height and weight, their BMI, and I do want to give you a caveat that, BMI in athletes is not the greatest thing. And that's because athletes weigh more. And so they tend to have sometimes a pretty reasonable BMI, just potentially, having pretty significant eating issues. So body composition may be a better option, although there's lots of things we don't know about that and where people should land in what range. But BMI can be a little misleading. It is easy, obviously, to measure the height and weight and calculate the BMI. So I think that's why that's in some of the RED-S and the Triad literature. Vital signs are super important. Athletes with significant eating disorders can be, very bradycardic. We often will get orthostatics, which can be helpful looking at their fluid status. You should look for hirsutism. And sometimes, you have to ask more questions about it because there's so many, things out there, and a lot of women are uncomfortable if they have that. And so, they maybe are waxing or using things that make sure that you can't see that they have hirsutism. So you have to ask about it. And, sometimes they laugh, especially if they don't have it. But if they do have it and they're doing something to take away, so you can't really see it, they're like, oh yeah, I actually do have that. So you have to really think about that and not just look for it and ask about it. Look for stigmata of eating disorders. A classic one is the Russell's sign, which is where if someone's bulimic and they're putting their finger down their throat, they can get a callus on the top of their MCP. So look for that. Sometimes they have bad looking fingernails, lanugo hair, other things like that. Look for signs of cortisol excess. Lots of our athletes don't have this, but if you have someone, you're like, oh, you start looking and you see some of those things, you might worry about an endocrinopathy. Breast development, particularly if you're trying to assess for primary Menorrhea. Nipple discharge, if they're having that, that's obviously, I usually ask about that. I don't necessarily test for it unless they say they have something. Doing some of these things in the training room is not the best place to do that. So you might want to bring them to your regular primary care clinic or things like that if you want to do a breast exam and a genitalia exam, trying to look at looking for normal appearing anatomy. The nipple discharge is a sign of hyperprolactinemia, and so that can cause amenorrhea or oligomenorrhea. All right, now we're going to get into the lab part of this, which this is a really nice schematic, and so I thought we would follow this one through. I don't personally do it exactly like this. I tend to get some more labs because almost always there's other things going on with the amenorrhea in an athlete. So it's kind of more of a not make them back and get a million labs kind of strategy. So to get the minimum for amenorrhea, you have to measure the FSH, the prolactin, and the TSH. Those are critical. And if you look at those, you can really work up most things with amenorrhea. So that's a great place to start. And so let's just hear if their TSH is elevated, primary hypothyroidism. That's the bone health doctor and me talking. Can give you amenorrhea, so that obviously needs to be treated. If your prolactin is elevated and you have a normal TSH, you should look harder for a microadenoma in the pituitary gland. So that usually involves getting an MRI of the sella turcica. Do note though that prolactin can be affected by exercise, so it's really good for them to try to get their prolactin level after they haven't exercised. Probably say a minimum of 24 hours. Like our Gopher athlete do it longer than that. They think, like we're crazy people, but you can't get a falsely positive one because of exercise. So if you have one that's positive and it's like a little high, you might think about repeating it if they exercised beforehand, before you get that MRI of the brain. Increased FSH. So this is a problem because this is basically premature ovarian failure. Okay, so it'd be like if you're checking for a woman who wants to know, like, their FSH is high, and then you're like, yeah, but it looks like you're going to be going through menopause soon. So that'll kind of get you into that category. So where you guys are probably mostly going to land is over here. You're going to get these labs and have normal TSH, normal prolactin, and the normal or low FSH. So you can have functional hypothalamic amenorrhea and have a normal FSH. So say you're all over here, so we're going to focus on this category now on this side of the diagram. And so the next step is to sort of say, well, do they have are they hirsute in any way? If they are, then you're going to measure testosterone, EAS, which is dihydroepiandrosterone dione sulfate. And then here's some metrics and some numbers that'll help you kind of know what to do if these come back elevated. So for someone with PCOS, and we'll talk more about this, they're usually either normal or mildly elevated. Okay. When you get a much bigger elevations, and you have to start thinking about congenital adrenal hyperplasia or some kind of adrenal mass that we would be worried about. I've never had this, and I have been in this for a really long time. Doesn't mean you won't, but of course, they're out there, but they're pretty rare. So over here, if they really they're not hirsute on exam, you can just probably start with measuring their free testosterone. Kind of if it's elevated, you get over here in this PCOS category. If it's normal, then likely you're in this functional hypothalamic amenorrhea category. So let's talk about FHA, so functional hypothalamic amenorrhea. So this is reproductive function that's suppressed along with the entire reproductive axis, all the way from the hypothalamus to the pituitary. So everything across the board suppressed. And this is usually in athletes because they're not having enough calories. So they're exercising a lot. Maybe they seem to be eating some, but they're not exercising enough to do everything that they need to do, like make your heart beat and have your hair grow and all the good things, like go walk to class and things. And so the body is pretty smart, and it's like, well, we're going to start getting a lot more efficient with these calories, and it starts suppressing your resting metabolic rate, and it starts suppressing things that are considered to be sort of non-essential. The good news is it's reversible. So it can go away. It's not rare like you know, weird genetic disease or something. And I have had a number of mothers and their daughters, when I explain to them that what they have is due to caloric deficiency, it almost seems like they want to have like a rare, something strange disease, like Turner syndrome or something. And I'm like, no, I don't think you really want any of those. They're so disappointing sometimes. So it's kind of an interesting discussion. Stress and illness can also cause this. And it's the most important, number one thing you guys should know about functional hypothalamic amenorrhea is it's a diagnosis of exclusion. And so I spent a lot of time working this up, and the vast majority of the time, it's functional hypothalamic amenorrhea, it's nutritional, and but I try to do my due diligence and keep looking for these other problems, because you really want to identify some of those other things if they're going on. I also want to point out that males can suffer from this as well. They obviously won't lose their menstrual period, but they can lose sexual reproductive function, have decreased libido, some changes in their sperm production. And we'll talk a little bit more about this later in the talk. So, you know, sometimes athletes say this to me, so, well, I'm not getting my menstrual period, so like, so what? I kind of like that. And you're like, yeah, I remember being pregnant and breastfeeding myself and thinking like, oh, that's kind of nice. I'm not really getting that. Kind of handy. But here's the problem. So what I talk to them about is this. So your bone mineral density decreases as the number of missed cycles increase. Bone formation markers in amenorrheic athletes decrease. So at a time of life where you're supposed to be putting on a lot of bone and kind of saving bone retirement, doing things that may not as good, not saving as much for down the road. And unfortunately for good bone health, you know, you have until you're about age 30 to sort of try to save a lot of bone for your retirement. And most of it comes when you're an adolescent. So it's a tricky time to have to do anything, I think, in terms of the saving. But so I try to explain that to them. We also know that with FHA that you increase your risk of stress fractures. So that gets athletes' attention. And the numbers are around 2 to 4 times greater than athletes who are having regular normal menstrual cycles. It can also have a negative effect on cholesterol. And it can also, this gets a lot of the runners' attention, this last one, where it's been shown that you can have decreased artery dilation. So it doesn't respond as well as it should. And there's an interesting study on ballet dancers with amenorrhea, and they documented this, and they've some folic acid while they're waiting to improve their nutritional intake, and they actually improved their artery dilation, but it wasn't quite as good as it should have been still. And so there's some thoughts that this can also include the arteries in the in line of the uterus, so in the endometrium, and that may also be problematic for some of these menstrual problems, breakthrough bleeding and different things like that. So I also talked to them about why menstrual status matters. And these are some studies that just show if you're amenorrheic, that you have lower bone density compared to athletes that have normal menstrual periods. The athletes usually who have the lowest bone mineral density, the best ones are usually like gymnasts or athletes in jumping sports, volleyball, things like that. The worst ones are usually amenorrheic athletes and swimmers. So sometimes when they know, they understand some of the spectrum, that helps them think about it in a different way. And this is an interesting study came out in 2015 that energy availability did not differ among the menstrual disturbances in a large sample of exercising women, but energy availability did discriminate in clinical menstrual status. So whether or not you had amenorrhea or eumenorrhea. So it's definitely related to nutritional intake. So here's some more things just talking about why energy status matters. You guys can read through that. Just some more studies to support it. And so this concept of energy availability, which is really the cornerstone of the Triad conceptual model as well as RED-S, is basically, what is that energy availability? So basically, it's the amount of energy you have left from what you've eaten. You've taken off all the calories you needed to support your exercise. And then you divide and normalize it by your fat-free mass. So basically it's like, do you have enough calories hanging around to do like all the other things that you need to do after you're done exercising? And here's just sort of a picture of that. And some people tend to understand that better. So, you know, calories consumed versus, you know, how many calories you exercised off. And here's the exciting formula. You guys probably love formulas. So I mentioned that. And here's an example. I think that usually helps people get a grasp on it better. So an example would be an athlete is eating 2,000 calories per day. So that, you know, that's pretty reasonable amount, right? It's not terrible. So people see this athlete eating food and having some meals and things, but they exercise about 6 calories per day, okay? So you subtract those two and then you divide it by her fat-free mass. You can calculate that or get a Dioxis scan. There's different ways of obtaining that number you can make. And she has a you know, an energy availability of 27.5 kilograms or kcals per kilogram of fat-free mass per day. So what does that even mean? So what is low energy availability? So there's some important studies from Dr. Ann Laux, who's a pioneer in this field from Ohio University. Sorry, not the Ohio State University. Just had to throw that in there for you, Dr. Nye. And they found that when you're around 45 for a number, that your energy balanced. So that's healthy, adequately nourished, and they're young adult females. When you get kind of down around 30, then you're starting to get near your resting metabolic rate, so getting kind of low. You're about 33% below your energy balance. You start having disruption or luteinizing hormone pulses, which I'll show you a little bit more about, and you have impaired bone turnover. There's some newer things coming out of Dr. D'Souza's lab. She's at Penn State, suggesting that a low ratio between your measured and your predicted resting metabolic rate is being acknowledged as a marker of low energy availability. And then I always like to remember this number, that amenorrheic athletes restrict their energy availability by 44 to 67%. So that's a lot. So eligibility, what about that? So thinking back to the menstrual cycle, you guys might remember that LH is released pulsatile fashion, and then as you get around the time before you're going to ovulate, you get a release of LH. And so it's an important hormone for having ovulation happen. And LH pulsatility is disrupted within 5 days after decreasing your energy availability by 33% in young women. So that happens pretty fast. And this is Dr. Laux's work. And she would take these women and she'd put them in this lab and control everything they ate and how much they exercised. And she said they were very groggy sometimes. So it was maybe not the funnest lab to be in. It's interesting to hear her talk about her study. And I love this because what she saw was that exercise suppression of LH pulsatility can be restored if you have enough calories. So basically, exercise is not the culprit. So basically, you can exercise as much as you want, but you have to eat to support that. And so exercise is not the bad guy. So I think that's an important message to take home. And it's also interesting to know that some women are maybe less susceptible to decreased energy availability. And I always say, you know, you can hear about some starving countries where, you know, there's not enough food, but women are still able to have, you know, babies. And I always sort of wonder about that. So there's some, you know, resiliency, and there's probably some genetic susceptibility, and there's some evidence to support that as well. And there's the newer thinking on this is that instead of it like being, oh, you have to be like above 30 or closer to 45, that maybe there's a more individual threshold for this number. So this is just the graphs of 2 athletes who are having normal regular menstrual cycles. Here's this is not an athlete, it's sedentary control and an athlete cycling. Here are their LH pulses. You can see throughout the day, there's a lot of them. And then here in these 2 different amenorrheic athletes, you can see that that's really blunted and there's much fewer of them. And so this was such important work that Dr. Laux contributed. So new thoughts on low energy availability. There was this randomized control trial done by Dr. D'Souza and colleagues. They looked at 35 sedentary ovulatory women. They followed 2 controlled ovulatory menstrual cycles. So they collected like their urine like every single day. would have to bring them their urine samples, and they would put in the refrigerators, and then they have enough space for them, and they just collected all these things so they could analyze all their reproductive hormone status. They had diet and exercise intervention of varying degrees of negative energy availability over 3 menstrual cycles. And here they found out. So this is kind of interesting. So here's bourbon, and here's energy availability. So remember I told you guys like 30 was the number we're kind of worried about. 45 seems to be a lot better. But what you can see here is that a fair number of women, even above 30, we're still potentially having, we're having menstrual disturbance. So even though they were in this better range, they were still struggling. And then there's another study that they did the same. There's this big study out of Penn State called the Refull Study. So Big 10, I have to say that again. And they looked at these women for a long time, they're amenorrheic and distance runners, and the goal was to try to restore their menstrual status through nutritional intervention. And they collected so much data, and they just continuing to publish all kinds of interesting results that are really moving the field forward. But they did show, despite that earlier thing that I just showed you, that your predicted probability of experiencing an abnormal menstrual cycle increased greater than 50% if your energy availability decreased to under 30. So 30 is still like an important number, but obviously it doesn't necessarily maybe hold true for everybody. And so she's suggesting that you think about an individual energy availability threshold rather than absolute, which is, a little tricky. I'm not sure I know exactly what that means clinically and how to, use that or apply that, but I think there'll be more to come. And then I think this is another strategy that I've started using. It's actually pretty interesting, trying to look at their measured resting metabolic rate versus their predicted resting metabolic rate, and seeing if they're underneath this ratio. And sometimes you have athletes, their labs look pretty good, their BMI looks pretty good. They're like, yeah, I haven't had a menstrual period in 4 years. And you're like, that's not great. And then when I actually look at it, sometimes I'm getting some pretty interesting information that can help guide the treatment and return and trying to get their menstrual status back on track. So a lot of people ask me about, who should get a DEXA scan if you have menstrual dysfunction in athletes. So basically, if you're high risk, triad high risk, which would be defined as Menarche greater than or equal to 16 years old, so kind of delayed, primary Menorrhea, or secondary Amenorrhea greater than or equal to 6 months. And that can be currently you're having that, or have you ever had that the first year after menstrual period. So let's say you got your menstrual period at 13 and now you're 15 and you stop having your menstrual period for 6 months, and then, I don't know, you decide you don't want to do, let's say, cross country, and then your period comes back. So after time, you would still want to consider getting a DEXA scan on that athlete because that was disrupting their bone accrual at a really important time in their development. Moderate triad risk factors, you actually need these factors plus one other thing. So oligomenorrhea, 6 to 8 menses over a 12-month span, so current or in the past. Menarche, delay, but not as much as the high risk category, so between 15 and 16 years old. And then you would need one or the other things, such as disordered eating or bone stress injury, something along those lines. And then you would want to get a DEXA on that athlete. And then finally, if they're on medications for greater than 6 months that impact bone health. And so one of the classic ones is Depo-Provera for contraception. That's kind of a bad actor in the bone health world. So I would usually get a DEXA scan on that person. And there's lots of reasons why people pick certain kinds of contraception, but maybe if they can or they're willing to, try to steer them in a different direction. It doesn't always work though. Okay, what about long-term bone mineral density? So bone loss due to amenorrhea greater than 3 years may not be entirely reversible. So you may never get the chance to build that bone up that you were supposed to get. And then this study by Dr. Drinkwater, who's famous and was, I think, she might have been the first or one of the very earliest female presidents of the American College of Sports Medicine. She's a PhD. found that despite several years of normal menses or use of OCPs, the mean vertebral bone density of former oligomenotic or amenorrheic athletes remain low over time. And this is an interesting study, or not a study, but studies put together. It's a slide I got from Dr. Nativ. So I appreciate her letting me borrow it. Tried to look at, how long did it take to return your menses once you started doing, nutritional interventions, and what happened to your bone density once you got your menstrual periods back. And so you can see over here in this column that it can take a really long time, right, to get your period back. So it's not, and I also, it's not like, oh, I'm going to eat better for a week and then I'm going to get my period next month. It doesn't work like that. And there's actually an interesting study by Julie Ahrens, who was, it's a case series, who was at UCLA when I was on the faculty there, that showed that it can be, for sure, on average, like a year and a half. I tell them, I'm not to get about it for a year at least, and sometimes it takes longer. So you can also see that sometimes the bone density did improve. So that's good and that's encouraging, but you may not ever get back what you could have had. It's getting late. You didn't give me a warning. Okay, let's talk about the non-pharmacologic treatment of functional hypothalamic amenorrhea. The first thing is weight restoration, and that's been shown in many studies to have a good benefits in terms of trying to get your menstrual cycles reestablished. So you can't just go from not eating very much to eating a ton. So you have to gradually increase. Sometimes you start by like 300 or 400 calories a day, and this gradually increases over time. You can also decrease your caloric output, which will help this go along faster. So less exercise. So, the athletes aren't always so excited about this. So sometimes we, are trying to find out, are you taking at least one rest day per week and trying to have really be resting and not, like, oh, I did the elliptical instead, but really actually be off. Calcium and vitamin D counseling is important. Meet with a dietitian. I think formal written treatment plan can be very helpful and get everyone on the same page. It does sort of change your relationship a little with the athlete. And we try not to call it a contract at the University of Minnesota because that sort of implies legality, but rather a treatment plan where everyone's on the same page. They may need mental health treatment, so that's something to consider. And we already talked about this. It can take a long time to restore menstrual function, and OCPs are not the first line of treatment. So please remember that when I was a fellow, that's what we did, but that is not that helpful. You're just basically sort of not addressing the underlying problem. Think they're getting a menstrual period, but it's actually just a withdrawal bleed. And so it's a little, like leading these athletes astray. It's like give them an antibiotic for their risk. It's quick, it's fast, but it's probably not really the right thing to do. All right. So the female athlete triad, there's a cumulative risk assessment. So if you want to use that to try to help you strategize some of these risk factors, it's based on known risk factors in the literature, and you can get an actual score. So over in this column is the risk factor. Over here is a low risk. So like good category, moderate risk, and high risk. So somebody who's got eating disorders is kind of like in a category of high risk. For this column, you get 0 points. This column, you get 1, and this column, you get 2. And so each of these, you could get 2 points worth, each of these things. So you can go down these and see kind of what your people are scoring, which is helpful. And then there's stratification guidelines. So full clearance is 0 to 1 point, low risk. If they scored 2 to 5 points, it's moderate. And grade 6 or greater is high risk. I'm going to skip this part for now. I do want to mention that the Red S also has a scoring guideline, and they kind of do this red, yellow, and green, which is a nice way to put for people to understand sort of how their risk is. Dr. Ackerman in 2019, this is an important study, did a randomized control trial with 3 groups of normal weight endurance athletes who are either low or amenorrheic. And they gave them a patch of estrogen continuously with progesterone patch cyclic, OCPs, or it was one group, so they're on the pill. And the third group had no hormones. And they had done this with anorexics, and they found some improvement. And what they found, Dr. Ackerman and colleagues, was that the patch group actually had an increase in their bone mineral density in 1 year by 7%. And that's pretty good in bone density world. So that makes me happy, you know, that they're not continuing to go down, and it's better than stabilizing. They're actually improving like they should be. The pill, there is a non-statistically significant increase of 0.4% and no improvement, basically no change, no hormone group. And so I did put here what that is. You'd probably want to look up this study to use it. I've used this in a handful of athletes, and we're seeing some results from it. Please know that this method of doing this is not for contraception and will not protect your athlete from getting pregnant. Male athlete triad, just today, the Female and Male Athlete Triad Coalition released a position statement on the male athlete. So you guys can look for that. And basically, there's been some work and some interesting information, and it started back, you know, quite a while ago, and there was a big summit in 2017 starting to talk about that. And Dr. Tim Forty has done a lot of work in this area, Dr. D'Souza. And so basically, these are studies that were showing that male athletes can also have some of these same problems, bone stress injuries, and suppression of the reproductive hypothalamic axis. And so we proposed and studied this, Dr. Tim Forty. Basically, it's the same cumulative risk assessment if you take out the menstrual period ones, and then you score them without that being in there. All right, I have time to talk a little bit about PCOS, and then we'll stop. I do want to say, and I know you guys have learned about this in your residencies and things, so we don't have to, you know, go through it ad nauseum. But I do want to say that in an athlete, it's actually sometimes very hard to make this diagnosis, because one of the mainstays of treatment, you guys all know this, is exercise. So you can get these female athletes come in with, you know, menstrual dysfunction, like maybe a Menorrhea or some Amenorrhea, and you know, they don't look like a PCOS patient, so you're not really thinking about that. And then you kind of work them up, and you're not really getting anywhere. And a lot of times you get their bone density is usually pretty normal because excess androgens is probably actually good for them. But you can have all these other problems, so it's super important, I think, to try to identify it if you can. Increased obesity, insulin resistance, diabetes, high blood pressure, dyslipidemia. And this is really interesting that to me, and I didn't really appreciate this, but there's a much higher rate of depression and anxiety and eating disorders in this group. And I'm not sure why, and I don't think they totally understand that, but it's the increased risk. Down here on the bottom, there is a nice website that has a lot of resources about education for this and how to treat it through years for people that have PCOS, and what their recommendations are for trying to diagnose it, because the criteria is, you know, there's different ones. There's like Rotterdam, and there's like I think there's NIH one, and they recommended this. This was a number of organizations that got together in an international, and they put this nice paper together. So you guys can take a look at that. I want to read more about it. They recommend sticking with the Rotterdam criteria. And I think it's important to point out that basically if you are an adult female, you only need 2 of these 3. It's a little different if you're a kid. And so if you have somebody that has, let's say, amenorrhea, and they have evidence of being hurt, you don't necessarily need to get an ovarian ultrasound, okay? So that's important to know. I think in our athletes, this part is a little bit harder, trying to see if they really have signs and symptoms of hyperandrogenism. And the biochemical just means that you find it like in their lab work, versus they maybe don't have any real outward appearance of it. So just know that I usually end up getting one of the athletes a fair amount, because I think it's a hard diagnosis to make in our population, even though I think it's pretty common. Here's just a person with some hirsutism. Here on the biochemistry, trying to get the assays, I think that you want to get a calculated free testosterone, because it looks like a direct free testosterone assay is not a very good test, so don't use that one. And then, you know, like if you're more worried about it, then I add in the DHEAS to go along with the testosterone. And then there was an interesting study that showed that in women who are lean and diagnosed with PCOS, you can find signs of insulin resistance. So sometimes looking harder for that side of the equation might help you. And then the ovarian morphology, just to remind you, it's not needed for the diagnosis. And if you're less than 8 years after your first menstrual period, it's not helpful. It's actually because the ovary can look like a PCOS ovary, but it isn't, and it's just a developmental phase of adolescence. So be careful about getting that and make a call on someone who's, fairly close to Menarche still. You want to get it, if you're going to get the ultrasound, and transvaginal is better. You want to do it on day 2 or 3 of your cycle. And then there's criteria, but this is a nice picture of a normal ovary, and then here's a PCOS ovary. It can have generalized sit in there, or it can like go in a circle and kind of, they call it a necklace pattern, look like a necklace. Treatment, we talked about this, it's diet, it's exercise. OCP seem to be good, or Mirena is an option in this population. Sometimes you need metformin, spironolactone to help with the HERSA. It can also help with the menstrual dysfunction, which is interesting. And please know that spironolactone is banned by USADA and WADA. So if you have the athletes at that level, you should be thoughtful about when they're taking it and if they should take it or not. So some people miss that one. It's getting more common for the dermatologist to prescribe spironolactone to younger kids. So sometimes they're having more athletes coming in on that. This is a nice slide that shows a good schematic of, if you're looking for pregnancy and you have PCOS or not, here's a treatment category. So typically you guys will be over in here with our younger athletes. All right, read this. This just came out too in June 2020. It's really talking, is another big committee paper put together about treatment and diagnosis of luteal phase deficiency, and I'll stop there. So just to let you guys know, our case, she ended up being such a good eater. She only ate 2 meals a day. She didn't eat any carbs. She could avoid it. She was very afraid of gaining weight. She thought it affected her performance. We got some labs. Everything was normal except that her FSH, LH, and her dial were all suppressed. And then we got a DEXA, which was kind of just average. So, it was in the normal range. So we, had her see the psychologist, or meet with a dietitian. She started doing more nutritional intervention. She showed in that triad, she was a 6. So that's in the high risk category. So we actually limited her miles some and tried to get her moving in a better direction. So that's the end of that story. So I'll stop now. And I hope you guys, thank you for hanging in there with me. I'm happy to take any questions, and I'm sorry to keep you so long in the evening.
No, Suzanne, that was awesome. And I was not about to stop you and give you a warning, because this stuff I just find fascinating. And so I was, very much enjoying all of this. I'd love to hear more of it. I don't see any comments in the chat, and that's been typical as of late. But I do have some questions for you, and I think our fellows might be thinking some of these same things. Energy availability sounds like, a number that I'd like to know for every single one of my patients, but a hard number to get. And, if we're calculating that as, I think what I wrote, I tried to take some notes, dietary intake minus the caloric cost of exercise divided by their fat-free mass. And right. I see all 3 of those as those take some work to get all 3 of those variables. How do you approach this in a practical setting? Who do you try to really dial in and calculate? Do you do this for a lot of your patients, and how do you do it?
Yeah, a lot of times the dietitians, the sports dietitians, or hopefully you're working with sports dietitians, they'll be familiar with this and can actually help you with it. And so that's been kind of nice, because we didn't necessarily have that back when this was first coming out. For a long time on the female and male athlete triangulation website, there was an energy availability calculator, which could help people. I'm not sure if it's there anymore or not. So I should check on that. I haven't looked at that for a while. I think that you can generally get an estimate, of what people are eating. You can have them do, a 2-day dietary recall. Our nutritionists or our dietitians will sometimes have them take pictures of things and send it to them so they can estimate that. There's some good online things like MyFitDay is one. You can get the one with the ads in it, so it's free. And then athletes can kind of get a sense of what their caloric intake is. And then I think it's pretty easy to sort of take a look at, there's some great resources to look up how many calories you're expending, right, when you exercise. There's all kinds of web-based calculators for that, depending on if you're, doing a light jog versus you're, running 6-minute miles or something like that kind of training. And then the fat-free mass, usually the best way is to get a body composition. So you can do that in a bod pod, on a DEXA scan machine. You could do a skin fold calories, although I do have some concerns about that because women who are worried about their body and their body image don't like having any of their fat pinched. So you can do it, but I would really be careful about who does that and how they do it and the kind of the speak around that. And then I think there's bioimpedance is a good option, but you have to do the pretest protocol, and those Tanita scales are probably not the greatest, the commercial ones. I think there's some much better ones, but trying to get a reasonable, body comp is probably the best way to do it.
Got it. And in terms of their energy expenditure, does that, are we leaving out of the equation like the resting metabolic expenditures, or is it just the cost of exercise specifically?
Yeah, it's the cost of exercise, and it's an interesting number to think about because I think people recover from that exercise too. And so that's not really taken into account very well. And then the other thing that they found in Dr. D'Souza's group with the Refull Study is that these athletes, they're also super active all the time, a lot of the time. So, they're like, oh, we're going to go for a hike, or now I'm going to go, paddle this kayak to relax or something. So they're actually expending a lot of calories outside of their sort of formal exercise. Right. That's really not very well accounted for sometimes. So that's something to think about.
Yeah, got it. And again, I this is maybe this is related, but I hope this is not disclosing my ignorance. But a DEXA scan will, I guess my cop out is that it's hard to get them in the military. We have very poor availability to actually get a DEXA scan for us in the military. But I see what I see with the report is a Z-score, their bone mineral density, but I'm not seeing their fat-free mass. Do you have to, is there a different technique? Is it the same scanner but different technique to get a fat-free mass from a DEXA?
No, yeah, that's a great question. There's different software. Okay. So all the big DEXA scanner manufacturers have it, but your place, they have to either buy it where it came with the machine or add it on. Mm-hmm. So the other thing is it's best to get your body composition on a measurement called total body less head. So that's the best way to do a body comp.
Okay.
So you can't do it like with the standard measures of like a hip and a spine, but in a younger person, you should be getting a total body less head anyways for their bone density in the first place.
Okay, got it. We do have better availability of bod pods, and I don't know if in the military there's a lot of those, and there's not so many civilian, but if I needed that, I'd probably go for a bod pod.
Yeah, and I think that's a great option. And the nice thing about a bod pod is it'll give you an estimated resting metabolic rate. And it's really interesting, like when you get it back, and there's like this high level Division I athlete comes back with a really low resting metabolic rate, like a sedentary person. And you're like, well, that's because they're so restrictive in their calories that they've really gotten really efficient with all their, and so trying to restore that is an important piece of the equation.
Wow.
So bod pod's a great option.
Okay, cool. I have a question about, does the quality of an athlete's diet matter? We talk a lot about just total number of calories, but are there specific nutritional deficiencies which factor in more heavily into the, the stress level on their hypothalamic pituitary gonadal axis and their menstrual
that's
function?
the question. Yeah, that's a great question. I think there's some studies ongoing that are trying to look at that in more detail and sort that out. But I don't think we know really the answer to that yet.
Mm-hmm.
I would say that one of the problems, sometimes, okay, I've been practicing long enough. Like when I started as a fellow at UCLA, the big thing was like fat-free diets.
Right.
Right.
Yeah.
It's like, my God, heaven forbid that you put like regular dressing on you. It didn't matter if it was good fats,
fat makes you fat.
And it was high carbs, right? And
right,
so
yeah.
a lot of pasta and things like that. And now it's sort of morphed into this like low carb, and there's like even on our own cross country team, there's like this high prevalence of athletes that are eating gluten free, even though they don't really need to.
Yeah.
And so sometimes, making that it's like a hard adjustment then to get enough calories. So sometimes I see that as more of the problem. And I think a lot of athletes also compare to, oh, well, lots of people need like this many calories, 2,000 or something. So I feel like I'm eating like my family eats, but they're exercising all these extra calories, and so they need to be eating a ton. And if you ever listen to Michael Phelps talk about when he's training really hard, he's eating like 10,000 calories a day.
Mm-hmm.
That's like a job in itself.
Yeah, really. That's a lot of chewing.
Yeah, it's a lot of calories. So yeah, and then parents will often say like, well, she seems to eat fine. I think it's fine, but it's way under what they really need.
Yeah. Really quickly, a comment. I worked in Air Force basic training for 5 years. And in that population, we see about 30 to 32,000 young men a year and about 8,000 young women, 40,000 trainees a year. And among those, young women, our prevalence of iron deficiency was astounding. It was, roughly 75, 80% of females had a ferritin under 45, and like 20 to 25% had an undetectable ferritin level. And it was, just high levels of anemia. But I wonder, in the course of that time, I found an interesting article on it's called The Unexplored Crossroads of Iron Deficiency and the Female Athlete Triad. It talked about the relationship, how iron deficiency can affect, hypothalamic function and menstrual function. I just wonder, it kind of makes sense to me that if somebody's iron deficient, their body might try to conserve iron by going into amenorrhea. But I don't know, do you think there's validity to that type of a reasoning? Maybe their body is just trying to protect itself from the losses either with menses or the cost of maintaining a pregnancy.
Yeah, I think that's like such an interesting area. And with the discovery of hepcidin, sort of the master regulator of iron transport in the body, and that effects, and Kate Ackerman, I think, has published something recently on this, sort of looking at your iron status and your menstrual function, and how like the more menstrual dysfunction you have, your iron status is more compromised, and hepcidin has a role and has an effect on some of the hormones of the reproductive axis. So I love learning about that, because to me, being a bone health person, iron's a super important, and then still we're sort of sorting this out, but factor in like bone formation.
Mm-hmm.
So I think we're going to see like all these things are all end up being related, but really understand in the long run. But yeah, I'm glad you read that article. That's great. That's a really interesting article. I thought so too.
Yeah, it was fascinating, one I've never forgotten. And, recently I moderated a lecture by Emily Krauss and on Red S. And, hearing this, moderating this lecture with you, I just keep thinking we need someone like you and someone like Emily. We need you experts down at our military basic training sites to, study these people and help get these factors under control. But with our recruits, who really are a little cross section of American youth, there is a high prevalence of these disorders, these nutritional deficiencies and poor bone health, and girls that have been on Depo-Provera for 6 years, and goes on and on. A lot of
Yes.
disordered stuff out there.
Well, I remember once I gave a talk on the Triad, and I talked about the male athlete Triad potentially.
Yeah.
I called it Matt. And Fran O'Connor was like our, speaker that we flew in to talk at this conference. And he, like, as soon as I sat down, he like hands me a note. I see Matt in the Navy SEALs. And so that was interesting. Like, I think there's a lot of parallels that really need to be explored with them. Some things that are happening with the military.
Yeah.
The warrior athletes.
Yeah. Yeah. So true. Well, thank you so much, Suzanne. And I see, again, I'm sure that the fellows who are dialing in on YouTube will be wishing that they had dialed in live. But that will wrap us up for tonight. Thank you again for spending this valuable time with us. And we look forward to seeing you at the annual meeting at some point. I hope you and everyone has a great rest of the evening.
No, thank you. And thanks everyone for tuning in. And if you listen to this down the road or you have questions, my info is in the AMSSM, member guide. So feel free to reach out, and I'm happy to help you with your hard athletes with these problems, or if you want to collaborate on research, or you have good ideas you just want to talk about, I would love to do that. So
good stuff. All right. Thanks again. We'll talk to you next time.
Okay. Thanks so much. Good night.
Good night.